Okay, so we'll go over our first injury scenario, and usually this will be done on the whiteboard in the lab, but this is just getting you to start thinking about the procedure that you would follow if you were assessing somebody for an injury, and the process that you'll go through for your actual injury scenario at the end of the semester. So for your injury scenario, you'll be given very little information. Soccer player running, plants to change direction, collapses down on the ground, complaining of lower body pain. And I might tell you it's on the lateral side of the ankle or the medial side of the ankle, but you're not given a whole lot of information. And then there'll be questions that you would ask to get more information. And a couple of key questions. What happened? So if you didn't see the injury, you want to know how it occurred. So through tears, the player will tell you, I was running and I went to plants and I went to shift directions and I felt something in my ankle. So you got a little bit more information. You know the pain's at the ankle. You want to know specifically where is the pain. So you can ask them, can you point to where you feel the pain? And in this case, they point to the lateral side of the ankle. So based on the injuries that we've covered so far, just to inversion and eversion sprain, you know that they likely have an inversion sprain. But there's more questions that we still need to ask. Rate pain out of 10, with 0 being no pain, 10 being the worst pain they've ever experienced. So they'd give their pain, say, a 5 out of 10. As soon as you know what their 5 out of 10, what their current pain is, being 5 out of 10, you want to know, well, what is their 10 out of 10? What's the worst pain they've experienced? Because that'll give you an idea of what their pain threshold is. If their 10 out of 10 is a fractured bone, the chances are they have a pretty good idea of what significant pain is. But if they say their 10 out of 10 is they had a paper cut and they ate some salt and vinegar chips and that really stung the paper cut, well, maybe their pain threshold isn't quite so good. Prior injuries, have they injured that area before? If so, did they go for rehab? Did they feel like they fully recovered, or were there still some deficits on that injured side from a past injury? What makes it better and what makes it worse? Now, the injury just happened. They may say, well, nothing makes it feel better. It still hurts just the same. But sometimes you'll be assessing somebody a few days after their injuries happen, and in the meantime, they may have found that icing helps it. If they elevate it, if they keep off their lower legs, that makes it feel better. Versus worse is spending more time walking, sitting for long periods of time without it elevated, and turning their foot inwards or into that inversion position makes it feel worse. Snap or pop. Did they feel a snap or a pop or feel the joint shift when the injury happened? And if so, that can indicate that it's a higher grade injury, so a grade 2 or a grade 3. If they did not feel a snap or pop and we don't have any swelling or bruising or any of those more serious findings, then we can be more sure that it's a grade 1. But snap pop for our course is going to indicate that it's a grade 2 or possibly even a grade 3 injury. Footwear, this typically isn't relevant for an acute traumatic injury like we have here, but it's still good to ask. Where we'll see it being more relevant is with our chronic gradual onset injuries involving the lower body, or medial tibial stress syndrome, or shin splints, patellofemoral pain syndrome, iliotibial band friction syndrome. Those are ones, plantar fasciitis as well, those are ones where footwear might be more relevant. And we'll talk about medications and allergies. Again, not too often that these are relevant or significant, but it's still good to ask. So medications, are they taking any medications currently? Do they regularly take that medication? So they might say, oh, I've been taking some Advil or Tylenol for pain or inflammation, but they've only been doing that since the injury. Hasn't been helping. Yes, no. Or they might be on a regular medication, and say you're concerned that somebody has a head injury, they're acting a little bit off or weird. Well, perhaps they're on a regular medication and they either skipped their dose for the last few times, or they found it wasn't helping, so they increased the dose, and that might be contributing to their altered state. Allergies, again, not too often that plays a part with their injury, but still good to ask. So that's your history. We'll move into our assessments next, and for assessment we're going to start with our observation. We're just looking at the athletes, and again, this might start when the injury happens. If you're watching the gameplay and you see how they move, or it may be them walking off the field, or you walking on the field towards them if they are unable to weight bear. So if they're walking, we're looking for any problems with their gait. Are they limping? If they can weight bear, we'll get them to squat, see if they can weight bear equally on each side, and get down to thighs horizontal. Can they go up on their tiptoes? So our weight-bearing dorsiflexion, weight-bearing plantar flexion, and for weight-bearing dorsiflexion, we could ask them to do knee to wall. We're also looking for any bruising, swelling, or obvious deformity, which could indicate a dislocation or fracture. So that all falls underneath your observation. If they are having difficulty weight bearing, again, we want to rule out fracture, so we'll do our fracture tests, our squeeze tests, and tap tests, and if they're negative, then we can continue on with the rest of our assessments. After observation, we'll assume that they have a bit of a limp and they're having difficulty weight bearing on the right hand side, and we do our fracture tests and they're negative for both of them. We'll move on to our range of motion, and we'll do active range of motion first. So we're active range of motion, the athlete is moving the body part themselves, we're not moving it for them. Our four main movements: plantar flexion, dorsiflexion, inversion, and eversion. And active plantar flexion is decreased, we'll say moderately, so 2 down arrows would be moderate, and they have moderate pain. So the plus sign indicates pain, and moderate is 2. Mild would be 1, moderate 2, severe would be 3. Dorsiflexion we'll say is okay, and they just have some mild pain. Inversion, decreased moderately with moderate pain, and eversion movement is okay, but they have a little pain with that, and we'll talk about why. So that's active range of motion. For passive range of motion, we're moving the body part for them. Plantar flexion, they're still decreased moderately with moderate pain. Dorsiflexion, we'll say they are okay for the range of motion. They don't have any pain anymore because we're moving it for them. Inversion, still decreased moderately with moderate pain, and eversion movement when we do it for them is okay with no pain. So that's passive range of motion. We're moving the body part for them. And lastly, we have resisted range of motion, or our strength testing. And for strength testing, we'll usually grade it 1 to 5, and typically most people are between 4 and 5 on strength testing. Even with a significant injury, it'd have to be a very severe injury to be below that, because 2 or 3 we're getting into not being able to even lift the body part against gravity at all. So resisted range of motion, so we'll do plantar flexion, dorsiflexion, inversion, and eversion. Plantar flexion, we'll say 4.5 out of 5 and moderate pain. Dorsiflexion, 5 out of 5, full strength, no pain. Inversion, 5 out of 5 and no pain. Eversion, 4 out of 5 with moderate pain. So this goes back to, with our inversion sprain, we can strain or stretch the peroneals, the muscles on the lateral side of the lower leg, and those muscles do eversion. So when we strength test eversion, there'll be noticeable weakness and moderate pain with that. Okay, so that's our range of motion testing. Next, we'll move on to our ligament stress tests. All of their pain is on the lateral side. We discovered that from our history. We'll do our anterior drawer and posterior drawer tests first and see if we have any laxity or pain with that. Okay, so our ligament stress tests are next. And anterior drawer, posterior drawer. So anterior drawer, we're going to put the ankle in just slight plantar flexion, maybe 10 degrees. We're grabbing onto the forefoot with one hand, we're stabilizing the distal tibia fibula with the other, and we're pulling the foot up towards the ceiling in line with where the foot is pointing. And we'll say that there's a bit of increased laxity and moderate pain, and all the pain's on the lateral side. Posterior drawer, there's no laxity, but they do have some pain on the lateral side of the ankle. So because all the pain is on the lateral side of the ankle, we're just going to focus on the lateral ligaments, more specifically ATFL and CFL. We're not worried about the PTFL because it's so rarely injured. To stress test ATFL, we're putting their ankle in plantar flex position and passively inverting. So our index fingers are over the lateral malleolus and the other index finger right beside it. While their ankle is in plantar flex position, we passively invert and we check to see how much our index fingers separate for the increased laxity. So with ATFL, they'll have a moderate increase in laxity and moderate pain. And the CFL, we bring the ankle up into neutral position. We passively invert the ankle. They'll have a mild increase in laxity and mild pain. No further special tests that we need to do that we learn, but in future labs there will be specific orthopedic tests that we'll learn for that particular injury. So since no special tests, we can move on to palpation, and we're palpating over the ATFL and CFL because we know now those are the injured structures. ATFL, we palpate there, moderate pain, we feel some swelling. The CFL, they have mild pain as we palpate there and just a tiny bit of swelling. Diagnosis, now if you said inversion sprain for your injury scenario and that's it, you would get 1 out of 3 for your diagnosis mark. You need to be more specific than that. So we know we've injured our ATFL and CFL. You said that you had an inversion sprain with those ligaments injured. You'd be up to 2 out of 3 now. We want to know what grade. So ATFL, the majority of our findings were moderate. They had moderate laxity, moderate pain with our range of motion, moderate pain with our strength testing. So that's going to be a grade 2. CFL, when we stress test it, there was mild increase in laxity, there was mild pain when we stress the ligaments, and there's mild pain on palpation. That'll be a grade 1. So mild corresponds to grade 1, moderate to grade 2, severe findings, so severe laxity, severe pain, that would be a grade 3. So you mentioned grade 2 ATFL, grade 1 CFL, now you're up to 3 out of 3 for your diagnosis mark. In the real world, you can have mixed findings. You'll have some things that'll be mild, other things that are severe, a few things that are moderate. So it gets a little more difficult in terms of determining what grade they are. But for your injury scenario and in the lab, everything will be cut and dry. Everything will be grade 1 or grade 2 or grade 3, so it'll be easier for you to determine. Everything will be mild, moderate, or severe, so it'll be easier for you to determine what grade of sprain that they have. Treatments, so for your injury scenario, you would describe what your treatment would be, and it'd be what we just talked about on the injuries. So everything that we mentioned for treatment there, you would describe as part of your treatment for the injury scenario, and giving 1 or 2 examples for each category. So that's our first injury scenario practice. We're going to do many more of these over the course of the semester, and towards the end of the semester, lecture 10 and lecture 11 are shorter lectures, so we'll take that extra practice time to go over some injury scenarios then as well.